For those of you who haven't met me, my name is Ajay Chari. I'm an associate professor of medicine at Mount Sinai, and I'm actually director of clinical research, but right today I'm tasked with talking about relapsed and refractory disease, aside from research. And part of the reason is there's so much interest in immunology that the clinical trials portion will be done by my colleague, Han Cho, who his main interest is translational work going from the lab to patient care with all the new immunologic approaches. So very exciting work. Stay tuned for that. Okay, so here's a patient case that kind of will set the stage for this particular topic. A 67-year-old man presents with anemia and back pain and has multiple myeloma and is treated with the triplet regimen most commonly used in the U.S., bortezomib, lenalidomide, and dex, followed by high-dose melphalan chemo and autologous stem cell rescue. And at day 100 after transplant, he has a very good partial response and elects to start lenalidomide or Revlimid maintenance and achieves a complete remission. 3.5 years later, while on lenalidomide maintenance, his myeloma relapses and he has anemia, moderately low platelet count, and kidney failure. And he wants to know what his treatment options are. By the way, I should mention some of these slides are most of the slides are in your handout. The ones that aren't will be again available online. So this case illustrates two concepts. When we talk about relapse and refractory disease, if you ever go, the NCI and the MMRF are both websites. If you're as a patient or a caregiver and interested in clinical trials, you can go there. And some of the jargon you'll see is relapse and refractory myeloma. So relapse just means recurrence after a response to therapy. So this patient has relapsed. Refractory means that his disease is progressing despite ongoing therapy. And this gentleman, as we learned, not only has he relapsed, but because he was on lenalidomide maintenance, he's actually refractory to lenalidomide as well. So he encompasses both of those definitions. And this chart is what many of my patients have seen this. I literally bring this to our visits in clinic. Every time we have to make a decision about changing treatment, the first question is clinical trials, non-clinical trials. And we'll talk about when you might want to do one versus the other. But if you're not going to do clinical trials, these are the main drug categories that we talk about. So I was just told about having to point at one or the other, but basically we have 5 drug classes: corticosteroids, which are dex and prednisone, the immunomodulatory drugs, which are thalidomide, lenalidomide, or pomalidomide, 2 proteasome inhibitors, bortezomib and carfilzomib, the conventional chemotherapeutics, melphalan. You heard about the high-dose melphalan with stem cell from Dr. Giral, but you can also give melphalan orally, and that's done in many parts of the world because of its cost. There's a 96-hour chemotherapy regimen called DCEP or DPACE, cyclophosphamide, which can be given orally or IV, bendamustine, also known as Treanda, which is intravenous, liposomal doxorubicin, also known as Doxil, which is intravenous, carmustine or BCNU, an old drug typically given in the setting of transplant with melphalan. And lastly, the most recently approved category, the HDAC inhibitor, panobinostat. So we basically have 5 drug classes with many drugs in each class. And the reason I mentioned this table is because while we have made a lot of progress in myeloma, we haven't yet gotten to a cure, and we're trying to get there. The flip side of that means that every treatment works for a while and then it stops working. So we're going to eventually cycle through all of these drugs in a given patient. And the question is, what sequence, what combination, and when do you use different drug combinations? And the other point, again, a plug for clinical trials, every treatment on here was only possible because patients participated in clinical trials. I'm not sure if people know if I wanted to take a medication that was sitting in the laboratory and saying, I want to test this in myeloma, first you have to show in the laboratory that it kills myeloma cells, then you have to show that it's safe to give in animal models, then you have to test what's the right dose to give in humans, then you have to see how well it works. So by the time a drug goes through that process, it typically takes minimum of about 8 to 10 years and many, many millions of dollars. And so every drug on here has had to go through this kind of a clinical trial. And that's why we're all united here with the MMRC, MMRF, and all of our collaborating institutions to really try to add more drugs in each class as well as whole new classes of drugs. But again, putting aside the clinical trials, what are the considerations when somebody does have relapse disease, like our patient scenario? One of the questions is, when did the disease relapse occur? Was it within 6 months? And this was brought up earlier by a patient question about potentially retreating. So if it was within 6 months, you might want to switch because it's a relatively short remission. Stem cell transplant would be another option. If it's more than 6 months, you could consider going back to the old treatment, switching classes, trying a transplant, and of course, clinical trial could always be considered. So how do we decide which treatment to pick? I mean, we had that huge toolbox, or as my colleague Dr. Jagannath likes to call it, somebody just brought it up at lunch, he calls it the box of chocolates. So we have these chocolates that we play with. So which chocolate do you pick and what combination? And part of it is, what are the prior therapies that a patient has had? How deep is that response? Did they get to a complete remission or partial remission? And what was the duration of that response? This is particularly important. We've been talking a little bit in this morning about high-risk disease versus low-risk disease. What's interesting in myeloma is that it's not that the high-risk patients don't respond. The question is the duration. And when the FDA is approving new drugs, they're actually much more interested in the duration of response, because you could have a great response, but if it lasts a month, what is that adding to the patient's quality of life and overall life experience? So the question really is both the depth as well as duration of response. Side effects, super important. This is a big segue into the next topic. We all struggle with quantity and quality of life, and sometimes we go in medicine so much to the quantity that we forget about the quality. And all these drugs will have some side effects, and every patient has a different experience with each drug. And one of the goals of oncology, and I always tell patients, why are we seeing you more often than, say, your diabetes or blood pressure doctor? And it's because oncology drugs have what we call in medicine a narrow therapeutic index. Too little, you don't get an effect. Too much, the patient has side effects. And how to keep that sweet spot of risk-benefit is one of the main reasons we have oncology as a subspecialty and why internal medicine doctors aren't prescribing chemo. Time since therapy we talked about, myeloma genomics. So we have many ways of determining the genetic profile of a disease. One of the best ways of explaining why this is so important is comparing myeloma to lymphoma. Lymphoma is also a B-cell cancer, but we don't just think of lymphoma as a basket case. It's 50 different subtypes of lymphoma. And each of those subtypes has different natural history and treatment interventions. We think myeloma is going to be just as complicated. It's just we haven't gotten to the point of making all of those different subtypes and assigning individual therapy. But the only way we're going to get there is with the study like COMPASS. This is a huge effort that you've heard about repeatedly. It's extremely important. Patients have to participate. Physicians have to encourage the participation, and there's a huge cost to profiling these patients sequentially over time. But that's what's going to tell us when a patient relapses. Why do they relapse? Why do some patients do better with certain drugs? All of that kind of information is going to help us move past the current toolbox that we have. The general health of the patient is super important. Diabetes, we all know in this room the side effects of dexamethasone, and believe it or not, it was a patient advocate who lobbied for a large U.S. study to compare high-dose dexamethasone to weekly dexamethasone. So if you think 40 milligrams of dex once a week is bad, we used to be giving 40 milligrams 4 days on and off 3 times per month. And that was what was being done. And it was a patient who said, you know what, why are we doing this when we have all of these new drugs? And studies show that that actually hurts patients. So for the most part, other than spinal cord compression or renal failure, very few patients will be getting 4 days of dex in a row because of that study. And again, it was a patient intervention. Yes, that's what I was, yes, and that's why I apologize, but yeah, these are going to be on the website. Yep, no problem. So diabetes, because of steroids causing elevation in blood sugar is a big problem. Blood counts, this is a big issue. If somebody has a lot of myeloma in the marrow, their blood counts will likely be low, and that's going to affect which drugs you use and also their eligibility for a clinical trial. And the organ function is very important. Heart, liver, kidney function. Why is this so important? If you're going to do a new clinical trial drug and the patient already has liver or kidney dysfunction and experiences some toxicity on the drug, how do you know if it's because of the drug or because the patient has these abnormal liver and kidney function? So whenever we test new drugs, we want to test it with essentially healthy patients, healthy myeloma patients whose only problem is myeloma and not a lot of other confounding issues that could cloud the picture. Neuropathy obviously is a big issue for patients with particular drugs, and there's ways to modulate that. Blood clots, the entire IMiD category of drugs, when given with steroids, can increase the risk of blood clots. So it's depending on how active a patient is, whether there's any, I always tell our patients when you travel, please get travel insurance and let us know if you're having long plane flights, because if you're on an IMiD taking Dex and you're on a long plane flight, that's a very high risk for clotting. And we often recommend additional medications to prevent clots in that setting. Personal lifestyle and preferences is super important. Some of our patients who come to our Mount Sinai live far away, and they're not able to come every week or twice a week for some of the treatments, and that would potentially be a big issue for what kind of option we pick. And of course, clinical trials. So part of the reason we would pick a particular treatment is also the amount of myeloma. So you've heard about the Krabbe mnemonic, and I've illustrated here just 3 representative time points in a patient's disease course to identify what might be the best time to do a clinical trial. Time point 1 might not be a good time because there's no disease to measure at this point. So this patient had a lot of, and for the sake of discussion, we can call it an M spike here about 6. When you debulk the disease and it's eradicated, there's no protein left to follow. So this patient wouldn't be eligible for a clinical trial typically. Time point 2 is, we'll come back to that because that's a little bit of disease. Time point 3, there's a pretty high disease burden. This patient might very well have some of those Krabbe symptoms. And you could argue if the patient is sick, that might not be a good time to do a clinical trial. Time point 2 is ideally the best time to do a clinical trial. So if you can intervene here, there's a little bit of disease, you can monitor the patient, they'll be eligible for the study, but they're not so sick that by the time you do what's called a screening, which is all the testing to go on a study, bone marrow, and then register the patient, start the patient, and you need to make sure that the treatment's active. So this is why in our program we try to steer patients in this group towards clinical trial, and this group we tend to use the treatments that I'm going to talk about in the rest of this talk. So one of the common treatment options is a proteasome inhibitor such as bortezomib or Velcade or carfilzomib with an IMiD such as Revlimid or pomalidomide, and they often get combined with corticosteroids, and that would be called a triplet regimen. You could also use additional drugs that are listed here, as I mentioned, Kyprolis or carfilzomib, Pomalyst or pomalidomide, and Feradex or panobinostat. So I'll just briefly go through these drugs. Many of you are familiar with them, so I'm not going to, and these slides are in your handouts, so I think just the salient points. Revlimid is an oral agent that's approved for combination with dexamethasone. Response rate in the initial studies that led to its approval was 61%. And I should just mention, when we talk about response in myeloma, we're talking about what Dr. Nisvitsky showed you that slide. This is the drop in the paraprotein. So 50% higher or drop in a protein is what's considered a response. And I mention that only because sometimes in the newer drugs, you may not get an official response by that criteria, but patients can still benefit. In other words, the myeloma was rising, and then the disease can be stabilized, or the Krabbe symptoms have been resolved. So, but when we talk about response here, these are standard, what we call IMWG response criteria, which is that 50% drop in the protein. The typical patient who was given Revlimid when it was first approved was stayed on for 16 months, and we know that it can be combined with many other drugs. Ideally, for somebody who's not had it, who's never progressed while taking Revlimid. One of the tricky parts is we're having more and more patients on lenalidomide or Revlimid maintenance, and so they're often getting these low doses. And one of the questions out there is, well, are they going to benefit from a higher dose? And the jury's not back on that one. I mean, there may be some benefit to titrating up the dose and adding steroids, but again, it depends on the disease burden. If you're having a little bit of protein rise, that might be something to try, but if the disease is really exploding, you may not want to just depend on a higher dose of Rev in somebody who is on Revlimid maintenance. And as you see in the last combinations, it's being combined with basically all the drug classes that we listed there, including the proteasome inhibitors, the novel monoclonal antibodies, including daratumumab, the CD38 antibody. Elotuzumab is a CS1 monoclonal antibody as well. SAR 650984 is similar to daratumumab, another CD38 antibody. And ixazomib is the oral borinated proteasome inhibitor similar to bortezomib or Velcade. So Revlimid can be combined with all of that. And that's another one of the reasons why we had that table, because usually we don't pair up 2 drugs within the same column. And we try to pick drugs from different classes because we know that there's synergy when you combine those, both in the laboratory as well as in the patient. And it's not uncommon that you can have progression on a doublet or two-drug regimen, and the third drug addition can actually rescue that patient. Proteasome inhibitor Velcade, approved for myeloma as well. Initially 43% response rate. Responding patients initially in the pivotal studies stayed on treatment for 31 months. Again, combinations are better. Similar messages, if you haven't had it before or progressed on it, obviously you can go back. You heard a little bit about the high-risk business. There are studies that now show that translocation 414, which is present in a fair number of myeloma patients, can be overcome with the proteasome inhibitor, which, and so one of the ways we think about it is risk has to be considered in the context of therapy. So for example, on none of the current slides in myeloma do you see deletion 13, which we used to talk about a lot 5-10 years ago. And the reason is, in the current era of drugs, that doesn't matter. And so similarly, translocation 414, 5 years ago, we used to call high risk, but now with the proteasome inhibitor therapies that seem to overcome them, they've been moved to standard risk. So risk always needs to be considered in the context of the treatments that are available when you're evaluating that risk factor. One of the nice things about the proteasome inhibitors, including Velcade, is that can be used in kidney dysfunction. This is very important, as you all know, for myeloma patients because of the CRAB, the renal insufficiency. Oncologists, we need to be very familiar with every drug's clearance, so much more so than perhaps our internal medicine and other colleagues, because a third of patients with myeloma have renal dysfunction. And if a patient has an impaired clearance of a drug, the dose of that drug has to be adjusted. Or you may need to pick a drug, an entirely different drug that is not affected. So there's also a big need for clinical trials for patients with renal dysfunction because they're often not represented well. The combinations, again, just like with Revlimid, you can basically combine it with all the other drug classes. You can combine it with the IMiDs. You can combine it with conventional chemotherapies like cyclophosphamide, and also with the novel drug categories as well. Kyprolis, or carfilzomib, is the same class as Velcade. The official label is for at least 2 lines of prior therapies, including Velcade and an IMiD, either thalidomide or Revlimid, and that they've progressed within 60 days or while on therapy. You'll see that this response rate is now 23% in comparison to the previous studies. What happens it's kind of an interesting number to think about. As we're getting more and more drugs, as our toolbox is getting bigger and bigger, it's getting harder and harder for new drugs to come in and show single-agent activity. So when, for example, Revlimid and Velcade were first approved, there were no prior Revlimid-treated or Velcade-treated patients. And so you see that those response rates were higher than this number, and the remissions were longer. And that's because those patients were typically less heavily pretreated. Now we're seeing patients who've had many of those drugs, and to ask a new drug to come in there and show gangbuster activity is much more hard, much more difficult. And so this is why a lot of new drugs either have a really novel mechanism of action or have to be combined with other agents. Elotuzumab is a great example of something that didn't show any single-agent activity, but it seems to show a lot more promise when combined with Revlimid. So it's an important part of drug development in myeloma, and it's important to talk about that because a lot of drug companies are a little reluctant to dip their feet in the myeloma space because it is getting so competitive with all of these drugs. And you heard how long it takes to get a drug approved and the cost. So we have to encourage these drug companies to continue in partnership with MMRC, MMRF, to continue committing to these novel agents for these unmet medical needs that we still obviously have. The response typically lasted 7.8 months in the initial studies with carfilzomib. And what you see here, what I was just alluding to, in people who did not have prior Velcade, the response rate goes up from the 23% to 42%. So less heavily pretreated patients are going to do better. On average, those responses were also lasted longer, 13 months. Same stuff about the high risk. There's some studies that show, again, treat translocation 414 with both proteasome inhibitors no longer considered high risk. Deletion 17p is a little bit more complicated, and it's probably beyond the scope of this time to talk about it, but there are some studies that show that maybe proteasome inhibitors can help mitigate some of the risk, but not completely eliminate that risk. Carfilzomib is a more potent second-generation inhibitor, but interestingly does not have any neuropathy associated with it for the most part. So it's a nice option for people who need a proteasome inhibitor but have had significant neuropathy. And to that point, bortezomib, most people, or Velcade, should be getting it sub-Q instead of IV, in other words, skin injection instead of intravenous, because that really diminishes the risk of neuropathy. Although there may be a little bit of redness at the injection sites, it's well worth it to minimize the risk of the neuropathy. Can be used in kidney dysfunction, and again, being combined with all of those other columns that we mentioned. And so the schedule for this is intravenously days 1, 2, 8, 9, 15, 16, and then a week off. And so 2 days back to back. There's some interesting studies with this agent exploring novel schedules, because we understand that this is cumbersome for patients to be coming to the doctor's office 2 days every week. So at this year's hematology meeting in 2014, there was a presentation to do weekly carfilzomib at much higher dose. So instead of giving small doses twice per week, giving a higher dose once per week. So that's an option that if those of you who are interested in or on it may want to discuss with your doctor. Side effects of this drug, fatigue, anemia, nausea, usually well tolerated, low platelet count. Patients can experience shortness of breath, 30% or so in the label, but most people are able to tolerate this well. Diarrhea, fever. One of the reasons a little bit of dex is given with carfilzomib is there can be some what we call infusional toxicities like fevers or chills, and that really is minimized with the dex pre-medication. Pomalyst is FDA approved for patients who've had at least 2 prior therapies, including Revlimid and Velcade, and have had disease progression either on it or within 60 days. The response rate was 29%, and the patients who responded were on treatment for 7.4 months. And so there's some data that, again, preliminary data indicating effectiveness. One of the, our fellow who graduated last year, we wrote a review paper about risk stratification of myeloma, and it's kind of a semantic but complex point to convey, but there's the difference between overcoming a risk and improving a risk. So translocation 414 is a good example of overcoming that risk completely because it's no longer high risk with the proteasome inhibitors. Improving means that if you didn't have that risk, you still, so for example, pomalidomide with deletion 17p, patients with deletion 17p who get pomalidomide will respond and do better than those who don't, but it doesn't mean that they do as well as those who didn't have deletion 17p. So it's kind of a semantic but complicated point to explain, and really, to really overcome high risk, we need to do phase 3 studies with 2 different groups, people who have it and don't have the risk, as well as people who get the drug and don't get the drug. So stay tuned for a better risk stratification, risk-adapted therapy, because that's really, we hope that the future of myeloma and medicine in general is personalized therapy, that patients who have a particular profile will be treated with a particular combination, and hopefully that the COMPASS study will help us get there. And pomalidomide also is being combined with all the other drug classes that are listed. Its schedule is similar to Revlimid, one daily, 1 day for 21 days, and then a week off. As we talked about, blood thinners are needed to prevent the risk of blood clots. About 20% of patients who get these IMiD drugs with steroids will have a blood clot. However, with aspirin, that can be reduced to less than 5%. And some patients who are at very high risk of having a clot, either because of having prior clots or long plane flights, et cetera, family history, might benefit from more than just aspirin. The side effects are listed here, basically lowering of counts. As you can see, anytime you see constipation and diarrhea, you see that it's going to be patient-specific. Shortness of breath. All these these drugs are pretty well managed side effects. Of course, there's going to be idiosyncratic or individual patient experiences. The newest drug that you may have heard about that got approved is Faradac, panobinostat. It's approved to be given in combination with Velcade and dexamethasone and in the treatment of myeloma patients who've had at least 2 prior regimens, including Velcade and an IMiD. The response rate was 61% overall, and it's for people who've had prior therapies as listed there. One of the side effects, I think, which will be mentioned here, so the schedule is orally. It's given every other day. So for typical schedule, as mentioned there, would be might be Monday, Wednesday, Friday, week 1 and week 2. And so when this study was done with Velcade, Dex, and panobinostat, one of the biggest issues was diarrhea. And so the way this pivotal study was done is everybody got Velcade and Dex, and half got panobinostat, half got placebo. And what we found was that the 3-drug regimen was superior in terms of getting better responses, but it came at the cost of increased diarrhea. So the placebo arm that got Velcade Dex placebo had about an 8% risk of severe diarrhea, and the treatment arm with the panobinostat went up to 25%, so about threefold increase. However, one of the caveats to that study is that Velcade was given intravenously there. And as we discussed, when you give Velcade in the skin, it's much better tolerated. And it has to do with the fact that when you give a drug subcutaneously, the drug is released slowly into the system, as opposed to IV, where when you give it as an IV push, you get a very high level. And so side effects are often correlated to the level of the drug as opposed to the slow and steady release. So we think that'll be mitigated by giving Velcade subcutaneously. And we actually have a clinical trial at Mount Sinai where we're giving this drug with Revlimid and Dex, and we've actually seen no diarrhea. And we've seen responses even in people who didn't respond to Revlimid before. The addition of panobinostat has really worked beautifully. So we have that presentation coming up at this year's ASCO. And it's being combined also with carfilzomib without the diarrhea. So I think it's a good example of how you do your initial clinical trial might result in the drug getting attributed to have certain side effects when it may really be the combination that's giving that toxicity. So what are the big clinical trials out there for phase 3? We have, Revlimid Dex with ixazomib. So this would be a completely oral regimen with ixazomib being the oral proteasome inhibitor. RevDex elotuzumab, this is the one that was the CS1 monoclonal antibody. The remission seemed to be very impressive, duration. We have some patients, we call them the Bridge Club. They've been on a clinical trial, and they've been together for so long that they play bridge every week when they come in. We have Velcade Dex daratumumab, Revlimid Dex Dara, which is the CD38 monoclonal antibody. Kyprolis with Dex versus Velcade Dex is a comparison to see. It's a head-to-head study. Pomalidomide with Velcade Dex. So all the permutations that you would expect here. And this is a more complicated slide, but this is, I think, why we're hopeful and encouraged with all the progress in myeloma. So what I've shown you here is the same drugs that we saw at the beginning in black, and we've added all the hot, new, and interesting drugs to show you where work is being done. So there's 3 additional proteasome inhibitors here. So ixazomib, aprozomib, marizumab. These are the next generation proteasome inhibitors. There's also 2 other HDAC inhibitors. Vorinestat's already FDA approved for another type of cancer, but ricolinostat is a specific HDAC6 inhibitor. This category of drugs, the PIM kinase inhibitor at last year's hematology meeting showed single agent activity. So this class of drug is basically what we call signal transduction inhibitors, which means the cell basically has signals from the outside of the cell into it to make it grow and stimulate proliferation, and these block those pathways. So PIM kinase is a good example. We have a couple of clinical trials with ibrutinib, which is FDA approved for other B-cell cancers, but it's being combined with carfilzomib. Folanisib, so this next category is drugs that interfere with the ability of the cell to divide because cancer cells are undergoing division more than typical cells in the body. And so kinesin spindle protein inhibitor called folanisib has shown some single agent activity. This is a really interesting drug that we also have at Mount Sinai, selinexor. It's a nuclear transport inhibitor, which basically, the importance of this drug is, those of you who saw the Emperor of Maladies show, you heard about the brake and the accelerator for cancer. So you have genes that are the accelerator that make them grow and the brakes that stop them. This drug basically increases the brakes of the nucleus to prevent cancer cells from continuing to divide. So it's a really interesting molecule that's showed in a lot of activity in many different tumor types, not just myeloma. And then we have the monoclonal antibodies, which is really the hot new thing. You know, it's kind of amazing that we give all these drugs to patients, but why don't they kill the rest of the body? You know, why is it that when you take a pill like an IMiD, why aren't you having all these other medical problems like hair loss and skin changes and all those other things? We don't know. That's the short answer. But the longer answer is this class of drug is going to try to get away from that nonspecific approach, really hit the target that you want. For example, CD38 with the daratumumab. And there's also work being done with new bone targeting agents. You'll be hearing in the next talk about bone disease is super important from a patient experience point of view. How can we do more than just bisphosphonates? So a lot of interesting work. So going back to our patient case, the guy who had initially myeloma got triplet RVD therapy, got transplant, Revlimid maintenance, and was in a complete remission. Then he relapses 3.5 years later, and he has anemia, moderately low platelets, and kidney failure. And so the reason this is why he's not necessarily the best clinical trial candidate. He's a pretty sick guy. Kidneys are not working. His blood counts are low. He may not even meet eligibility criteria for clinical trials. And so this patient would be better served at this moment in time with the conventional approach with drugs that are not going to be renally cleared. And so bortezomib, cyclophosphamide, and dex, or Cybor-D, would be a perfectly good combination for this guy. And it would bring him, and he responds well to the treatment. And then at the next relapse, whenever that may occur, that might be a better time to do a clinical trial rather than at this moment in time. And so to summarize, we've made a lot of progress in treating relapsed and refractory myeloma. People can get multiple lines of therapy. Basically, we're going to go through that whole box of chocolates. Treatment can sometimes be continued for extended periods of time. We generally at Mount Sinai prefer to start with 3-drug approaches. The idea is if you have a high disease burden, knock it down quickly, and then you can de-escalate to 2 drugs, 1 drug, and go to maintenance, as opposed to sometimes the community physicians start with 2 drugs and then try to catch up. So particularly when you have somebody with renal failure, time is important. Time is kidney, so you want to act quickly. And with each drug, there's all these different combinations, and you're going to hear even more about clinical trials in the future. So with that, I'll stop and happy to take any questions. Thank you. Yes,
there's a lot of information about viruses treating myeloma, a lot of publicity on that. I didn't hear you mention anything about that today. What is your feeling on that?
Yeah, because I was trying to stay to my task assignment, which is approved drugs. So you'll be getting more about that from the clinical trials. But I think viruses are, like with all the immunologic approaches, it's going to be an interesting area of research. Probably the biggest thing that people have heard about would be the measles virus. But one of the limitations in that study was, it's a typical phase 1 dose escalation study where you start with low doses and you have to keep titrating up. And really, there were no response. And then just at the very, very high maximal dose, there was a patient that responded. And when expanded, it looked like the only people that really might have that benefit would be people who were not immune to measles, which is very uncommon in the US. So it speaks to the generalizability of that particular approach. I think the Mayo group, which presented that data, is moving on with other approaches and other viruses. But the broader category would be called oncolytic viruses, basically using viruses to attack cells that are rapidly dividing. But stay tuned. Right now, I don't think we have a prime time candidate yet for the typical myeloma patient. Any other? Yes?
Talk a little bit about that, and also
Sure.
If the renal issues are resolved, are those patients more likely to have the renal problems come back, and how do you deal with that?
So basically the question is about renal failure patients. So in a newly important generalizable message here for everyone is myeloma kidneys are precious and we try to protect them. So we tell every patient that comes in our door, avoid non-steroidal anti-inflammatory drugs like Motrin, Advil, ibuprofen. All of those are kidney damaging agents. Tylenol is much safer. Secondly, avoid all intravenous contrast with CT scans. While MRIs and PETs are okay, intravenous CT scans should be avoided. And there's a lot of technology, MRI, PET, ultrasounds, you usually shouldn't do that. So those are general applicable for everyone. For the patient with newly diagnosed myeloma who has renal failure, there's actually data showing that if you treat effectively and the patient responds, these patients have a comparable course to patients who present without renal failure. And that's a testament to all the novel drugs that have been approved. But if we were to go through that table, pretty much you could use all the drugs there, and the drugs that would have to be modified for kidney dysfunction oh, there we go. So, oops. Let me go. Okay, so steroids, very easily to use in renal failure, no dose reduction required. Thalidomide and pomalidomide, no significant reduction. Lenalidomide is renally cleared, so you have to adjust the dose. These 2 drugs you don't need to adjust and can be used. Melphalan has to be adjusted. This is why dialysis patients, for example, can get a transplant, but you have to reduce the dose of the Melphalan. Cyclophosphamide, very easy to use in renal failure. Our colleagues in nephrology use it a lot. Doxil can be used. DSEP can be used, but it has to be modulated. These two drugs do not require significant modification. We don't have yet much data for this drug. So, but basically, you can, again, go through all of these drugs in different combinations and permutations, but would have to adjust the drug. And the earlier you can reverse the renal dysfunction, the better. And people, just because they have initial renal dysfunction, that doesn't mean that they're going to keep relapsing every time. And one of the reasons we're also getting better at preventing renal dysfunction is because historically we used to have to put all of you through those repeated 24-hour urines, which we still do periodically. But the serum-free light chain is a really good surrogate and in some ways is more reliable than the urine collection because the urine collection is subject to degradation in the warmer temperature. You have to do a full collection. It depends on the volume status, whereas the free light chain tends to be more reliable. So in somebody who has renal dysfunction, the first uptick in the free light chain, you might, you want to jump ahead and keep ahead of that. But we do need more data. And in fact, every drug that gets approved, the way it works is first tested in normal patients with normal renal function. And then if you want to get a label from the FDA to use it in renal dysfunction, and we have a study, actually, some of our patients in the room have participated in the study. For example, ixazomib, our center is the lead accruer to that drug because it's a great thing for our dialysis patients. Imagine you spend 3 days of the week already getting dialyzed, and now you have to go to the doctor's office the other 2 days. It's really miserable for the patients. And this drug would really change that because it's an oral proteasome inhibitor. But we're doing the formal, what we call pharmacokinetics, which is how does this drug get cleared by the body, and that'll allow the label to have renal dosing guidelines. So it's a really important. And lastly, I would mention that these monoclonal antibodies are not cleared by the kidney, so it's a great class of drugs to add to the arsenal. So a lot of interested work in renal failure.
Are there any studies about, let's assume you have multiple myeloma and you're on a maintenance Revlimid low-dose Dex, and then totally apart, you're diagnosed with another cancer, and the doctor says, oh, for that I need to put you on chemo. But wait, I'm already on chemo. Can you take 2 chemos at the same time, or does one size fit all?
And this came up a little bit earlier about the whole issue of secondary malignancies. We do know that these IMiD drugs do increase the risk of cancer somewhat. But we also know from the Swedish studies that even people, before they get any treatment, MGUS and smoldering myeloma patients have a higher risk of getting secondary cancer. So there is an inherent genetic, probably instability that predisposes patients to myeloma. It's uncommon, but it's known compared to the general population. That said, then it comes back to the specific of the patient. So for example, I have a patient who has breast cancer that's active with concurrent myeloma, and 2 of the drugs on here have very good activity for breast cancer, cyclophosphamide and Doxil. So we can combine those and try to hit 2 cancers at once. So we work with the other oncologists treating the other tumor types to try to find the best cocktail of drugs. Yep.
Could you talk about how you keep up with the research? It seems overwhelming, certainly, to me.
I would say it's even harder to be a general oncologist. At least I have a disease that I focus on, but I don't know how the community docs keep up with all the different tumors, which is why I think we have to work as a collaborative fashion, right? Not every patient can come to Manhattan and get all the treatments here. So what we try to do is partner with the local oncologist and guide them and hold their hand, say, here's the regimen, here's the doses, here's the schedule, you'd give it, and it's good for the patient and the doc, and then they come back. So by no means am I an expert, or any of us are in the room who are specializing in myeloma, experts in all cancers, but that's the trade-off. Either you're a generalist or a specialist. So you know a lot about one thing or a little about a lot. But you got to pick your poison. Well, you see that, I think this is one of the real testaments to the MMRC is the fact that we could have filled this entire panel with just one institution, and in some ways you could consider this competing institutions, but we're all in the same boat here. We're all trying to help advance myeloma care, and I think it really is collaborative. And we all sit on the International Myeloma Working Group meetings, and we've all seen each other ad nauseum at many, many meetings. So I think it is a collaborative effort. And I think the Europeans do a much better job in part because of drug access. They're forced to work together. I think, the rates of clinical trial participation in the US are dismal, probably less than 10%, 5%. Europeans, 30 to 40% of European patients are participating in clinical trials. in contrast, American pediatric oncologists, 90 to 95% of pediatric oncology is on a clinical trial. I think it's because it's so rare that they know that in order to really advance pediatric oncology, they have to collaborate. Oh, drug access. So the dean of Stanford School of Medicine said that you can divide healthcare into quality, access, and cost. And you can have 2 out of those 3, but you will never have all 3. And I think in the U.S., in some ways, we do not have universal access yet. We do not have low cost by any means. We spend far more than most Western countries. But if you define quality as getting these hot new drugs when you want them, yeah. But if you define quality as like low neonatal or maternal mortality, we're horrible. And in contrast, in Europe, you have universal access, low cost, but if you want quality, which is hot new drugs, you're not going to get it. The only way to get them is in a clinical trial. So it's socialized medicine versus non-socialized medicine.
Okay.
Yeah.
Yeah, you mentioned neuropathy, particularly with Velcade, and that there are ways to modulate that. I'm hoping you can expand on that. In particular, what can I do to modulate neuropathy and stay on Velcade?
So I'm going to briefly mention that because that's going to be a great segue to Dr. Scarborough's talk. But so you can modulate the dose of bortezomib. Lower dosing will help. The frequency, instead of twice weekly, weekly. The route, instead of IV, sub-Q. Look for other causes of neuropathy. So B12 and carnitine deficiencies are easy to fix. Those are nutritional supplements. And there's some data that alpha-lipoic acid, vitamin E can also be helpful. So those are the main strategies to try to help with neuropathy. And Dr. Scarborough, who's our colleague in palliative care medicine, will be able to comment further. Sorry? Oh, I'm told we have to. Oh, one more question. Okay. Yes.
Hi. You mentioned the importance of genomic analysis in when somebody has relapsed. What I'm wondering is how far along are we with multiple myeloma in being able to say, okay, if you've got this genomic profile, then this is the drug combination that's right for you?
It's a really good question. We definitely don't have, we're not at the point where we can do this for every patient in the US across the board in myeloma. But I can tell you that the translocation 414 is one example of a specific mutation that might affect therapy. Unfortunately, if you look at this table of drugs, we really don't have any biomarkers that say, okay, if you have a low level of this or a high level of that, you should get this drug. And that's where we need to get. But I can tell you some of the interesting work that we've been doing at Mount Sinai. We have one of the largest, Eric Schott is a world-renowned informatics person, and he was recruited from California from a biotech, informatics. And I'll get to what that means in a second. But basically, what they did was really cool. They took, for example, inflammatory bowel disease, and the patients weren't responding. They screened, they took the genetic profile of the cells and screened it against a battery of drugs that are available already commercially to try and predict where that you might see an activity. And interestingly, they found a anti-seizure medication, which had no previous use or activity in that disease, and found that it seemed to help. And that's now moved to clinical trials and shown a clinical benefit. We're doing the similar thing on a case-by-case basis. It's basically called drug repurposing, where a patient who has relapsed myeloma, we would take their bone marrow aspirate and work with our informatics colleagues to try to get a personalized output for that patient about maybe drugs that may not even be on this table, may be completely unheard of, and maybe for scleroderma or lupus, and it seems to have a signal. And obviously this has to be has to be done under a supervised clinical trial setting. I sit on the IRB, where Institutional Review Board, we can't just go testing any drug willy-nilly. So you have to show that there's a scientific rationale, the drug's approved, and then you could try these off-label uses.